Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Welcome back to Unraveled, Understanding Complex Illness. I'm Eileen Ruhoy.
And David Kaufman.
And we are back to our regular scheduled program.
Right. We're going to try to make up for the previous episode where we clearly were misbehaving.
We're so naughty.
Oh, God. All right. This is going to be easy. We're just going to talk about drugs.
Yeah, I mean, this has been sort of on our list for a long time. We get a lot of questions on Patreon about specific use of drugs. And I think that we'll have several episodes because obviously we can't cover every drug we use. But I do think that for this episode, we should focus in on a couple of them. And we get a lot of questions about LDN, and I do think we should start with that one.
So just as a preamble to the whole thing, I would like to say this is the way we think about it, and the way we do it. And actually, you may do it differently than me, and you and I may do it differently from Tanya Dempson or Larry Afrin or Pradeep Chopra, et cetera, et cetera. You know, there's a reason it's called the art of medicine. It's not like a joke or a stupid name. There is a lot of art to this, particularly in medication and titration, and particularly because while pharmaceutical companies get an FDA indication for a drug at a dose, it doesn't mean that's the right dose. Right? There's this bizarre idea that one dose fits all, and that is about as stupid as you can imagine. And it's the reason you and I will always start with a low dose and gradually titrate up. And it's not just because we have complex patients. The truth is that's what should happen to all patients. But it gets lost in the shuffle. You know, a lot of people say, "Well, I thought the dose was 25 milligrams twice a day," and I'll say, "Well, yeah, that's how it was tested, and nobody died in the phase 3 trial, so that's the dose." But that doesn't mean because you have a 2D1 genotype SNP mutation, you may metabolize it faster and need twice that dose, or vice versa. So, quick preamble.
No, and that's exactly right. I mean, so those classic dosages come from those trials, and then that's what they're reported as, and that's what they're published as, and therefore that's what becomes the classic dose. But, you know, people aren't classic. Right.
And LDN, low dose naltrexone, is a perfect example for this kind of conversation about dosing.
Yeah, and I will say that over the years, like I'm shocked when I get a patient who's already on LDN, and I ask, well, what dose are you on? And then I get this whole story about how they first started at this, and then they went to this, and then this happened, they went to that, they changed it to this, and every story is different. So it's clear that there's a lot of different protocols, and it's very patient dependent. It also seems physician dependent. And I was actually very interested in the recent article by Norman Marcus, who I mean, he's a great pain doctor out in New York. Yeah.
So before we hit the actual details, a moment of history, okay? Now, for those that don't know, and I think probably all of our patients know LDN because we live and breathe LDN. Naltrexone, the N in LDN, is a drug which blocks opioid receptors. So it's given in 50 milligram doses to addicts to help them not use their drug. All right, it's a kind of treatment to make it easier, I guess, to avoid the drug because you won't get any benefit from it. Okay,
right.
It was discovered in the middle or late 80s during the HIV epidemic in New York by a doc in New York named Bernie Bahari that it had benefit for HIV patients. And
wow.
He just, to this day, I don't know how he figured this out. But he did, and that's where this started being used in this low dose. That's where the 4.5 milligram comes from. So I'm getting way ahead of ourselves, but just to say it, there is no clinical trial data whatsoever on the planet that I'm aware of that actually shows 4.5 is the target dose that we should always use, even though we always do it. We'll talk about it.
Right. Well, some doctors are going higher.
Yes. Yeah. Right. But I'm saying a lot of people think it's 4.5, but what we're about to talk about is that's not correct. All right. Anyhow, I think the history of the drug is really interesting. So let's go.
Right. As opposed to naloxone, right, which is for overdose.
Right. Exactly.
Yeah.
So So the traditional teaching for LDN is, traditional is probably not the right word, but whatever, is you start low, and low for me usually meant 0.5 milligrams to 1.5, and you titrate up on a weekly basis, adding whatever increment you started with, okay? And, I had in my head a sort of a loose algorithm or whatever, that I would use the 0.5 dose if I had a patient with lots of sort of neuropsych stuff that I'd be concerned maybe there'd be a problem. And the idea of the taper was to get to 4.5.
Right.
And do that to avoid side effects. Taper up slowly to avoid side effects. Biggest side effect being sleep disorder.
Mm-hmm.
But it's clear to me over the last many years of doing this that number one, as you said, and I saying, I don't know what dose to take. I have, maybe if I was taking it, I would need 9 milligrams and you might need 2 milligrams, all right? And that's a fascinating idea that we forget in medicine. And then Norman Marcus wrote this paper recently that came up in Masterminds in our listserv, which was really fascinating.
Yeah.
Okay. So, and it takes the tapering up, it doesn't turn it on its head. It actually elaborates on it in a much more intelligent way.
Absolutely.
Normally I think you used it the way I did. You start at a low dose and you taper up over 3 to 9 weeks, and then hopefully the patient noted benefit. Okay?
Right.
And just as
I usually start at 0.5, but in his paper he starts at 0.1.
0.1.
Yeah.
Right. And
I'm shocked there's any effect at 0.1. And I understand, he talks about hormesis and how it's a hormetic drug, which it is. But I just feel like 0.1, I just can't imagine, although he does obviously titrate up. So I don't think many patients just get any benefit from just 0.1 a day.
Yeah, and I'm not sure. I want to try his regimen, which we'll explain to people in a second. But I am concerned about how long it may take to get to. I'm already concerned on the 0.5 milligrams, how long it takes. And that's partly my personality. I want things to happen fast.
Yeah, no, I think our patients want them to happen fast. So, and it's hard to explain to them. We need to sort of take this slowly, you know.
So before we get into that dosing, I don't know if everybody's familiar with LDN and why we use it. It is a go-to drug. It's probably the only one of only 2 types of drugs I'll prescribe in the first new patient visit before I have data back. Okay, in general. So I like to describe it to patients as having 4 major benefits that we know of. It improves gut motility, which is a big issue for autonomic dysfunction patients and SIBO patients. I was going to say miraculously, but it's not the right word to use, but surprisingly, helps with pain to an amazing degree for patients, can do it. It modulates the immune system, meaning it helps restore homeostasis and balance, and it decreases inflammation in microglial cells in the brain to help brain fog.
Yeah.
If you think this is one drug is doing those things that we know about, okay? It's incredible.
No, and there's improved mood.
Yes, it's really amazing.
Because of the decreased microglial activation.
Yeah, it's amazing, and I suspect it probably should be used much more widely, not just in long COVID and ME/CFS
well,
patients.
I think it is being used more widely. I mean, it has roles in a lot of neurodegenerative disorders, and in fact, I'm seeing more and more neurologists use it for diseases such as things like MS and NMO.
That's fantastic.
And Parkinson's even.
Great.
Yeah.
That's great.
And so I think it has a widespread use, and I think it should be considered for almost every disease.
Right. Of course, what that means is that some company is going to come out with a pill, patent it, and now the price will go 100-fold high.
It's already expensive.
It's not that expensive.
Really?
No.
I'm always hearing how expensive the compounding pharmacies are charging.
Right, but you can actually just prescribe the 50-milligram pill and patients can compound it themselves. I don't taper up doing that way, but then they can go on.
That's true.
The only negative of that is now they're in the system that they're getting naltrexone.
Right.
And the insurance company thinks they're a dope addict. You win some, you lose some.
I know. Yeah, so historically I've always started, well, that's not true. Early on when I first started using LDN, I did start at 1.5. I said start at 1.5, take it at night, and let's see how you do. And I would give it 2 to 3 weeks. And then if there were no benefit, but they were tolerating it just fine, I would go right to 3. And I agree. I had the 4.5 in my head,
Yeah.
and that's when I started doing LDN. That's what I was doing. But then over the years, as I learned more about LDN and read more, and had more experience with it with patients, I started to sort of tweak that a little bit, and I started to start lower. Then I would start at 1, then I started at 0.5, which is sort of what I still do now until I read Norman's paper, and I thought, I'm going to start at 0.1 now. But, and I have found that, it's funny because some patients when I started at 1.5 would have adverse effect. And now when I start at 0.5, I very rarely have that kind of concern. And then some patients at 1.5 would not have any benefit. And at 0.5, I get some benefit, interestingly. And so I still will go up just to see if we can get more benefit. But usually when there's a benefit at 0.5, at least in my experience with patients, I typically don't have to go past 3. Like they don't get any further benefit.
Right.
So it's just an interesting kind of drug in that regard. And I think it just speaks to its, the paradoxical nature of its engagement with the mu receptor, and sort of how this low dose can just like engage it enough to sort of create all these different, benefits that you described.
Right.
So,
and that's Marcus's whole point in the paper, that because of the nature of the drug and the pharmacology of the way it works, you can't know in advance the right dose, which probably is true for every drug. And so he's looking for his maximal effective dose, and he starts, unlike what I do, but I'm going to try this now, starts with 0.1 3 times a day.
Yeah, I saw that. That's fascinating.
And it's a little complicated for patients, and that's a concern. Will the patients manage this? But so day 1 is 0.1 once a day, and then for 3 days, you do that for 3 days, and then if everything's okay, you go to 0.1 twice a day for 3 days, and then 0.1 3 times a day for 3 days, and then you go up to 0.2, 0.1, 0.1, and on and on and on until the patient says, I feel great, and then you go up another one, and if they don't feel great, you drop back down to, and that's your dose.
Right.
So it's sort of brilliant.
It is brilliant.
It just takes a while, and the patient has to kind of sign on to this methodology, which is not so
and
easy.
As you know, at least from my perspective, like one of the complicating issues that I'm always having is that I don't have any patients who are completely naive to drugs, and so they have lots of other drugs on board. And even during this titration, probably other drugs are added for various reasons by various doctors, not always by me.
Sure.
And so, I often wonder about that kind of confounding, effect, right? So if there's other drug, polypharmacy is a real thing. We talk about that all the time.
Right.
And so it would be nice to sort of see on a patient who's not on any medications and have symptoms how this titration of LDN would really do for them. I think that would be a little bit more pure in sort of an understanding of how this protocol can work for a patient than just adding it to their list of drugs, right? Don't you think that's
No, I agree completely. And the not one, but a concern I have with Norman Marcus's method is that he's a pain doctor, so he's really prescribing it primarily for pain. That is not my primary reason for prescribing it in general. Right. So, his that dosing schedule may not be quite as applicable, but I think it's worth a try.
Yeah, I completely agree with that. And I'm prescribing it for neuroinflammation. That's my main goal.
Exactly.
And not everyone does well on it.
No, it's not.
So that's I get it. What are the most common side effects you hear? I hear a lot of like vivid dreams and
So vivid dreams which interfere with sleep.
Yeah.
Although sometimes then I say take it in the morning, and they say, well, it makes me sleepy. So it's confusing. And let's see if I remember this correctly. The initial pharmacology and rationale for the way it worked is you give it at night because it blocks opioid receptors in the gut, which tells your brain to make more endorphins, which is why it helps with pain.
Right.
And I think that's probably accurate, but it does not address all the other benefits.
No, it doesn't.
Which is why his dosing method 3 times a day is so interesting to me.
Right, which I've never done.
Yeah, never
so 3
done.
times a day, that's
sometimes I do twice a day, but I've never done 3 times a day.
Well, it's like ketotifen. I always start at once a day, and then I go to twice a day, and then I go up on both dosages in a day.
So, as a quick aside, what this conversation about LDN is a good example of what we were ranting and raving about in the previous episode. Here's a drug.
Yeah.
We're using it beyond off-label.
Beyond.
Okay? And now, even though you and I have been doing it for 5 to 10 years with LDN, I was doing it back then, so longer, we're still learning and still experimenting with the best way to do it. And it's a perfect example of how much we keep learning and experimenting and work in progress and trial and error. And anytime the insurance industry steps in, it just blows it up. Because LDN is mostly compounded, it's one of the few drugs I can basically say, screw you, I don't have to deal with you, to the insurance companies.
Right. You still have to deal with compounding pharmacies.
Yeah, but compounding pharmacies are fine.
Yeah.
Unlike CVS, compounding pharmacies answer the phone.
I know.
They say, hi, doctor, how can I help you? How can I help you? I mean, 80, my nurse, she says the different that she doesn't mind calling compounding pharmacies at all because they're so nice and they answer the phone, they actually help, versus calling CVS, you get cut off 3 times, they leave you on hold. And they say, what does the doctor want? Give him 90 days. It's...
Rite Aid is the worst.
And yeah, so I have no problem with compounding pharmacies.
That's really funny.
Yeah,
yeah, I agree. Compounding pharmacies are definitely a different beast. Yeah. But yeah, it still requires calling it in. It's hard to electronically prescribe.
You
electronically prescribe?
You can fax it or
okay.
electronically do
I sometimes I find it hard to sort of get across what I want to do with the drug, with the titration of a specific compounded drug.
I don't write that in the prescription.
Oh, you don't? You just...
I just tell the patient.
Okay. Got it. That's interesting.
Yeah.
I try to get the pharmacist on board.
If you send a prescription to CVS for, I can't think of a drug, and you write down, take as directed.
Yeah.
Which in my older days, that's how you often wrote a prescription, okay? They won't fill it. They'll call me up and say, what do you mean take as directed? We can't use that. The insurance company won't cover it. So I no longer write that. I'll write, let's say it's propranolol, I'll write 10 milligrams twice a day. And I tell the patient, do not follow the directions on the bottle. Do not, do not, do not. And I'll emphasize it, I'll capitalize it, because I want them to start with half a pill once a day. That if I put that in the prescription, then I'm going to get 3 phone calls from the pharmacist. What are you doing, doctor?
I agree. Yeah, no, it can be really complicated trying to sort of manage these medications.
Back to the other episode.
We don't want to go back to the other episode. So, right. So, okay, compounding pharmacies, we like them. Okay.
So, LDN.
LDN, so I love that drug, frankly, because when it works phenomenal. Yeah. I mean, it really does.
And it's important for patients to understand, don't give up on it quickly unless you have bad side effects.
Right.
It often takes a month or 2 to kick in once you hit whatever that maximum effective dose is.
Right. And we always talk about that. We can't just give up on a drug after a week and just because it didn't work.
Right.
Right. Assuming that you're tolerating it, we just sort of have to play with the dose a little bit to see if we can find an appropriate dose for you that you will get clinical benefit. Right. So that's an important point.
And similarly, and this is true for almost every drug we're going to talk about, if the patient says, I tried it and it made me sick, or I tried it, it didn't help, that's not a reason not to try it again. Often they tried it the wrong way. They weren't properly directed for tapering, or they're a different person. So, they're less sick, or they're more sick, or they're on other drugs that may or may not help. So I will often say, all right, but I think we should revisit it, after we get to know each other, or whatever it is. So, one try doesn't rule it out unless you had some, catastrophic reaction, anaphylaxis or something like that.
Yeah, no, for sure. I agree.
Yeah.
So we both agree that LDN is a good drug.
It's a great drug.
And I too will prescribe it on the first visit while I'm doing the workup.
Actually, it's making me think I should just try it and see what it's like.
Yeah, maybe I think I should too, actually. When I read Norman's paper, I did have that thought, like I should try it.
Yeah, interesting.
Prescribe it for me and I'll prescribe it for you.
I wonder if actually it would have a use in the longevity world. Because if you
I'm
think
sure
about
it would.
those mechanisms that I just said.
I'm sure it would. Why wouldn't it?
Got a new project. Okay.
Reduction of inflammation.
Right.
I mean, reduction of pain. I mean, it's microglial, deactivation. I think it should be looked at in the longevity world. Wow. Along with rapamycin and
acarbose.
Acarbose, yeah. I got to start using that more and more. Anyway, okay, so next drug. What's the second most common drug you use?
Oh, drugs in the POTS world.
The POTS world.
Yeah.
Yeah, so I've been going off the grid with a little bit of mast cell stabilization a lot lately, largely because the Cromolyn shortage sort of sent me in a path of like, what am I going to do for these patients? I feel like a lot of my EDS patients, a lot of their symptoms are not about the histamine. And while, they can all be on as much Claritin and Allegra as they want, I really like to stabilize those mast cells. And so, I've been doing a lot. I find that a lot of different drugs actually stabilize mast cells more than you would expect. And I think I might have mentioned them in previous podcasts, but things like nortriptyline and amitriptyline and the CGRP receptor antagonist class. Obviously, benzodiazepines, which we talked a lot about, which I love benzodiazepines for mast cell stabilization.
Right.
They're
They're
phenomenal.
They're amazing.
And I use a lot of lorazepam, and I think they've gotten a bad rap, frankly, the benzos in general as a class. And I obviously everyone's got specific pharmacogenomics that I think are important to look at when you're trying to choose a class of medication for a particular patient. But I think the majority seem to really respond well to benzodiazepines, which work on the GABA A receptors, but also actually affect other ion channels.
So when you're using it for mast cell, how do you dose it? How do you start?
Oh, I start really low, like really low. Like I usually give them a 0.5 tablet, which is the lowest it comes, and then I tell them to cut that in half.
That's what I do.
Yeah. And then I tell them to take it at night because obviously it's got a sedating effect. But over time, people say that it's not a sedating, and they're not even using it for sleep.
Right.
They're using it.
And what's really interesting about the benzos, you're right, they have a terrible rap, and I'm so sick of defending them and hearing the patient tell me my doctor won't prescribe it, et cetera, et cetera. So all that said, Larry Afrin makes this point often, and I agree. You don't need big doses. Most patients will have quite dramatic results with 0.25 to 0.5 3 times a day. It's amazing. And they don't get stoned. They don't get high.
Right, no, exactly.
They don't get sleepy. They don't keep upping their dose.
That is so true.
All the things that the world is afraid of. They don't have dementia. So again, they're great drugs.
They are great drugs. And so while I don't necessarily prescribe them at the first visit because I'm still gauging the patient and how they feel about benzos, I often, obviously as a neurologist, I hear a lot about the headaches that are associated, and usually they're refractory headaches and they've been to headache specialists. And of course, the kind of patients we see have sort of these more, some, I used to say obscure, but I don't even think they're that obscure anymore, but other reasons for headaches that are not classically discussed in the headache world, things like CCI, of course, and compression, intracranial pressure issues, which are not classic IIH. They don't have papilla edema, So I use a lot of acetazolamide. I really do. I always say, let's do I call it a trial, acetazolamide trial, and see if it helps your headaches.
Tell me how you do it. Well, because that's part of what we want to have people see. Is
right, no, absolutely.
How we use these drugs.
Well, so it's important so first of all, in neurology, acetazolamide is used for a lot of things. It's used for seizures. It's used for headaches. It's used for, obviously, mountain sickness. Everyone knows that. That's what it's classically known for. But it's also used for, like, very specific kind of migraines, like hemiplegic migraines. It's used for certain hyperkinetic disorders, like there's these dyskinesia disorders that it's used for. So acetazolamide is used for a whole lot of things.
It's also used for channelopathies.
And for channelopathies, it's exactly right. Like periodic paralysis, we use acetazolamide, though there's a better drug now that's Keveyis, which is a similar drug to acetazolamide, but it's a lot more potent, and I like it better for periodic paralysis, but hard to get approved. But I've got a phenomenal rep who helps me. So anyway, that's another topic. We could talk about that drug on another episode. But acetazolamide is a carbonic anhydrase inhibitor, and carbonic anhydrase is an enzyme that basically catalyzes the hydration of carbon dioxide and the dehydration of carbonic acid. So it decreases intracellular pH by increasing the level of CO2 within the cell. And so in that regard is how it decreases neuronal activity, which is why it's been effective as an anti-epileptic medication. Though I will say it's not commonly used for seizures. It's usually what do they call it? An adjunctive therapy. That was the word I was looking for. Because we have so many anti-epileptics in our arsenal now that are way more powerful for seizures in general, but it can have a supportive effect for sure because it does reduce neuronal activity and neurotransmitter release. And so, but in doing so, it's classified as a diuretic because it reduces the amount of fluid that is produced, specifically the cerebrospinal fluid, which is catalyzed by carbonic anhydrase. And so it inhibits that enzyme.
Wait a minute. It reduces, I know it reduces CSF production, but it does that as a diuretic?
Yeah, it's classified as a diuretic.
No, I know that. But it's not its diuretic action that
No, it's not its diuretic action. No.
It's a terrible diuretic.
The production. No, yeah, it doesn't work on the kidneys.
Right.
It works on the production of fluid. So it reduces the production. So so we use it for elevated intracranial pressure. And, a lot of these times, these headaches, while may not be directly related to the intracranial pressure itself, is often indirectly related. So because of some other anatomical concern, anatomical diagnosis, anatomical misalignment. So I will very commonly use acetazolamide for that reason. It's a sulfa drug, so some patients have a sulfa allergy.
And how do you dose it? Do you always...
So dosing, yeah.
Is the dosing vary by the indication?
Not really.
Indication,
No.
indication.
No, I mean, I always start low,
okay.
But my low, because if I'm trying to treat a refractory headache, like I'm not going to start at like 50 milligrams, right? So like I'm trying to at least get the potential of a therapeutic benefit initially while trying to start low to make sure that they tolerate the drug. I start at 125 3 times a day, and then I quickly go up to 250 3 times a day, and then I go up to 500 3 times a day, especially if they're getting a response. The most common side effects are these paresthesias of the hands and the fingers, and sometimes around the mouth, perioral, yeah. And I will often warn patients of that, and I will say that it's usually transient, and will usually get better if you can stick with the drug. There has been the occasional time where a patient says, this is just, I can't even sleep at night because of these things. And I'll either lower it to the dose where they did not have those paresthesias, or I'll just discontinue it. But that, and then, of course, like with every drug, obviously you can get GI, you can get nausea, you can get stomach upset.
Fatigue,
I say take it with food.
A lot of patients complain, surprisingly.
Of what?
Fatigue.
Fatigue, yeah, for sure. Dizziness,
right.
Yeah, so but I would say that applies to every drug we use, right? If you look at the inserts for all these drugs, they all say that. So, but I think specifically to acetazolamide, it's the paresthesias. And then if for whatever reason they develop like kidney stones, which is a common concern with acetazolamide, you can definitely get kidney, which is also why those patients are on the ketogenic diet. I sometimes will say I'm afraid to put you on acetazolamide or topiramate for that matter, which is another medication that I'll regularly use that has weaker carbonic anhydrase.
Sure.
Topiramate, Topamax, as we call it, Dopamax, because you feel dopey on it.
Right.
But it also has weak carbonic anhydrase inhibition activity, not as potent as acetazolamide, but it too can sometimes precipitate kidney stones. And so with a ketogenic diet, you're already at greater risk of that. Right. So sometimes I ask about their diet, not always, but if one of these drugs are effective for them, we talk a little bit about a dietary component to sort of being able to maintain that drug without increasing the risk of kidney stones.
And for intracranial hypertension, you'll start at the similar 125?
Yeah, I start 125 3 times a day. It is, 3 times a day, as you know, like some patients can't, they forget.
I start usually just once a day, and then I'll move up from there.
Once a day, I wouldn't expect any benefit. I mean, I don't think that's wrong because our patients are very sensitive to drugs in general, but I wouldn't expect any therapeutic benefit. And I guess, I just feel like these patients are suffering with these headaches, so I just want to try to help them quickly. Yeah, but so I really like that drug for a lot of different reasons, and a lot of patients respond. In fact, many patients who have internal jugular vein compression that we're finding now more often than I ever would have expected.
Another one of those things. Where did this come from?
Yeah, I know. It's like the list just keeps growing, right? A lot of the surgeons won't do an intervention until they first have trialed acetazolamide.
Right.
Just to see if there's a benefit, then there's clear.
I think further a takeaway here for patients but especially physicians is it's a drug to always consider. Why not give it a try in a patient where headaches are an issue, where there's even a remote suspicion of intracranial hypertension. Parentheses. There's no question, at least in my mind, that ME/CFS patients have a huge incidence of intracranial hypertension. So it's probably worth a trial in every single patient.
Well, that was my point at the beginning when I was saying that in neurology we use it for a lot of different things. Right. So I agree with you. So doctors shouldn't fear at least trialing it at the lower dosages, right? Because it's not like it's just got this one indication, and unless you have it, like you're scared to use it for anything else. We use it for a bunch of stuff.
And it's been here for 50 years.
It's been around
you're not
for a really
find some sudden unexpected.
Right, exactly. Climbers and ultra athletes use it regularly when they go to high altitude places like Jackson Hole and Denver and stuff. So, So that was my point, is that, it's been around for a long time. We use it for a lot of different things. It's certainly worth a try.
Exactly.
If you have a complex patient who clearly has, connective tissue disorder, has refractory headaches, or has other, neuroinflammatory kind of symptoms. It's definitely worth a try.
I think it's worth saying that you and I and our colleagues are masterminds on the listserv, 500 plus doctors. Our approach is often trial and error, and you don't have this indication, but let's just give this a try.
Yeah, no, absolutely.
We're not sure of all the ways things work, and this has this mechanism, so maybe it will help.
Absolutely.
I can give you a good reason, but I'm not really sure. Let's give it a try. So that concept, that approach to treatment applies across the board to our patients and how you and I often make decisions. I mean, ideally, we make the decision based on a clear mechanism of action that we think will help the patient, but we don't always know that.
No, we don't. And again, a lot of our patients have symptoms that, sort of are symptoms of a different diagnosis, right? But they don't yet meet the criteria for that diagnosis, or the workup is negative for that diagnosis. But regardless, there are symptoms that are similar. And so I very often find, like, how a lot of our patients have periods where they just feel like they'll say that their limbs are weak or they can't climb the stairs. And I know it's part of the fatigue phenotype. I always think about it, but sometimes I think about it how it is like periodic paralysis, for example.
Yeah.
So and I think acetazolamide occasionally helps.
Right.
As does pyridostigmide, which is another drug.
Along the lines of thinking out of the box and we don't understand, in our patients, as we've talked about in many other episodes, that the whole septet concept and the interactions between the different pathologies and the bidirectionality, we can't always know that pathology A isn't actually causing pathology D.
Right.
All right? So I had a patient yesterday, just a quick story, but I think it's useful to say and actually discuss bringing this patient on the episode.
Great.
She's just amazing.
Great.
It's very complicated. I'm not going to go to the whole thing. I just want to tell this one little tiny story. So she's on a trip to Europe. She's doing much, much better, okay?
Nice.
Europe. Oh, no, I think she went to March Madness to watch basketball, something like that, okay? And in the middle of this trip, suddenly her legs get so weak she can barely walk, and she starts having trouble thinking, and she gets a rash, okay? She forgot to bring her Cromolyn.
Oh, wow.
Her Cromolyn gets FedExed overnight. She takes her Cromolyn. Oh, and she was incontinent. And she takes her Cromolyn, everything disappeared. Now, there's no way in hell, frankly, that I would have ascribed every one of those symptoms. Oh, of course that's MCAS. Of course that's your mast cell. But it's an example of what I'm trying to say, which is we can't always know which pathology is driving which symptom.
Right.
So you take your Cromolyn, which isn't even supposed to get absorbed out of the gut, and it helped her entire phenotype presentation. Or you take your Cromolyn, other patients, and it helps their POTS.
Right. No, that's really interesting. And, I personally would love to do like an episode on Cromolyn, but a lot of patients ask me, so am I just taking the Cromolyn for my gut? And I always say no, because it's got an interesting systemic effect. And, I think I'm in the minority when maybe this is not a popular opinion. I don't subscribe to the idea that MCAS is a primary diagnosis. And maybe you're like, yeah, no shit, Sherlock. But, I just sort of see it as a secondary diagnosis, like something is pissing these mast cells off, and they become just hyperreactive. And I mean, so your story is a perfect example of how I see mast cell involvement, right? I don't think that a patient has a primary diagnosis of MCAS. I think a patient has a secondary diagnosis of MCAS because there's some particular trigger that doesn't necessarily have to be an exposure, by the way, but can be another pathology, another
one of the ways to
diagnosis
to conceptualize it that supports what you're saying. To me, in general, all or most mast cell activation syndrome patients, that is simply, probably not the right word, but simply an immunologic reaction to some event.
Yes.
Okay?
Right.
And usually that event is some sort of infection.
Right. Usually, but not always, is my point, right? So, like, if you have an underlying other disorder that may or may not have been identified yet.
Too.
Yeah,
okay?
Exactly.
Now, that can happen, and then the MCAS, or the mast cell activation degranulation, takes over to some degree, and just it's like putting mud on the whole picture because it confuses everything. And I mean, just think about this woman's symptoms; they make no sense. If you think about it,
No, I
as
agree.
an internist or a neurologist, what do you mean? One thing could cause your brain fog, your incontinence, your leg weakness. You couldn't walk up the stairs. And what was the other thing? I already forgot.
Rash.
Rash. I mean, yeah, the rash we could get away with. But
Yeah.
but I know it can do all those things, but it doesn't.
Does she have tethered cord? Because that sounds like tethered cord.
It's a whole long story.
I would have said
It's
tethered
such
cord.
an interesting
I would have, honestly, if I would have gotten a call from a patient with those symptoms, I would have said, go to the ER. I'm worried about cauda equina.
And her tethered cord was cured with Cromolyn. Right? I mean, that's
I look
so
crazy.
amazing.
Like,
So let's talk about Cromolyn. We can talk about. Why'd you say? You didn't?
well, I mean, because I just feel like we're running out of time.
Well, too bad. So we'll do more episodes on this. So Cromolyn is a really interesting drug. There is some debate to its effectiveness as a mast cell stabilizer. I've made a decision. I'm not even going to get involved in those debates. This is on Masterminds, okay? The drug works.
Yeah, I agree.
Doesn't work for everybody. It probably works for 50, 60% of patients. But when it works, it is fucking amazing.
Right, and I often think that it does prove the point of the interaction of the gut with everything else.
Yes,
right?
exactly.
So, and that's why I tell patients, no, I know that you don't necessarily have a primary gut you don't have SIBO and you don't have any of the gut disorders, but it's got a great systemic effect, and I think it's just because of its effect on the mast cells that line the gut.
And I think that effect is not necessarily dependent on whether they have an elevated CD117 count, although obviously that helps support the diagnosis, but you don't have to have high mast cell counts in your gut for Cromolyn to be effective. I think it's important to point out for physicians listening, you can't just start Cromolyn. You have to taper it up very carefully because it will cause mast cell activation, degranulation. And that's another example of what I said about LDN. Many patients have said, oh, I tried it. It was terrible. I got so sick with it.
Yeah.
How did you take it? Oh, I took 200 milligrams 3 times a day. Well, of course you get sick. It's not the patient's fault. They just didn't know. And, so I have a tapering schedule that I have patients use. Of course, I don't write that on the prescription, as we just said. I just write the way it's supposed to be. Please don't follow directions on the bottle, et cetera, et cetera. But it's very important that you taper it up.
And how do you start the taper?
I start with 50 milligrams once a day.
Of the Cromolyn?
Of Cromolyn, yeah. And then I, dissolve the vial in a glass.
So you take half a vial.
And you drink half the glass. Put the other half in the fridge. Tomorrow,
you start really low.
I start really low.
Okay,
and if you're
I don't start that low.
If you use compounded, it's a 100 milligram pill. You dissolve it, and you open it and dissolve it. And it takes about 2 weeks to get to 200 3 times a day, which is the initial target dose for me. But like LDN, there is no target dose. It's whatever the best dose is. So I have some patients who take 8, 9, 1,000 milligrams 4 times a day, and they love it. It's great.
Wow.
And then some patients are on 300 or 200 3 times a day, and that's doing the trick.
Yeah.
So tapering it up is important.
That's interesting because I start at 100 milligrams twice a day. You start way lower than.
Way lower.
Yeah. Wow. I haven't had a problem with 100 milligrams.
Serbo. You can steal my DLK Chromo taper. Chart parts.
I will. Chart parts. I love chart parts. I've been adding some chart parts to your Serbo. Have you noticed?
I have not noticed, but I need to see.
Yeah. No. So I have seen your Cromolyn chart part. But yeah, I've always just started at 100 milligrams twice a day.
So one last little thing about this patient yesterday. So I said to her, how could you have forgotten it, right?
Yeah.
And she said, well, it's such a pain in the ass. You got to carry
These
the
vials,
shoebox full
I know.
of stuff. I said, well, let me just prescribe some compounded Cromolyn for travel. And I suggest this to patients. Yes, you pay out of pocket. It's less than your copay most of the time. And now you have a little bottle of capsules that you can travel with all over the world.
That's brilliant, actually.
Instead of literally, for those of you who don't take Cromolyn, it comes in a shoebox.
I know, it literally does.
One dose is this long, like a little vial, but that's just one dose. So you might take 12 of those vials in a day.
Yeah, no, it's great. Yeah. I always warn patients, when you go to your pharmacy, don't be
surprised. Bring a suitcase.
Yeah, I know. No, but that compounded trick for travel is something that I hadn't thought of.
It's also great even without travel.
Yeah.
It's just so much. I have patients, their copay really is more than the compounded.
Okay, I'm going to start offering that to patients.
Yeah.
But yeah, Cromolyn is for sure one of my favorite mast cell stabilizers. I mean, if not the favorite, but again, because of the shortage,
Right.
I was forced to think once again outside the box about the mast cells. And I have found that some of the drugs that I've been using my whole career turn out to be mast cell stabilizers and have actually helped quite a bit.
So let's move on to another drug. We'll jump around from pathologies, okay?
Okay.
Just to make people keep them on their toes.
Keep them on their toes.
So you want to do Gabapentin?
Oh, Gabapentin, yeah. I mean, I use that a lot.
Okay.
Do you use it a lot?
I do.
Yeah.
Not a lot, but a fair amount.
Yeah, I find it's helpful for, obviously, its indication is for neuropathic pain, but it also does stabilize the mast cells. They get a lot of...
Does it actually have that indication?
No.
It doesn't, right?
Of course not.
Yeah.
But it does improve a lot of the symptoms that are related, especially the clear histamine symptoms. Gabapentin does help. It reduces inflammation. You know, I know you've heard me complain this. People think it works on GABA receptors. It doesn't. It works on the voltage-gated calcium channels. So it does not, well, it looks like GABA, which is why it's called Gabapentin. But it does not interact with the GABA receptors. And neither does pregabalin, by the way. They both work on voltage-gated calcium channels.
Is there any, I'm getting a little diverted here, but do you see any particular advantage to pregabalin, Lyrica, to gabapentin, other than the fact that it's heavily advertised and more expensive?
I think my opinion is that the formulation of gabapentin is such that you use what seems like such high dosages that, like, if someone's on, 1,800 milligrams of gabapentin a day, and I say, oh, you can take 150 of Lyrica twice a day, they somehow prefer that. I think it's all like
okay. So they're actually,
but I think they are interchangeable. I don't see any greater benefit from one over the other.
That's what
they both have a similar mechanism of action.
It's just another big pharma scam. GABA came off patent, so they
exactly. That's exactly what had happened. And you can't get Lyrica approved, although I think it's changed now, but there was a long period of time when you couldn't get Lyrica approved until they first had tried and failed gabapentin, which made no sense to me. So anyway, but it's really effective for neuropathic pain. It's really effective for neuralgia. So a lot of our patients have different neuralgia. So glossopharyngeal neuralgia, trigeminal neuralgia, occipital neuralgia. It's really effective for that. It's really helpful for sleep.
That's
my God, my patients love it for their sleep. It helps like those weird like leg movement. I mean, obviously restless leg movement. It's long been known to help. But our patients, because of the spinal involvement, the spinal cord involvement with EDS, they have a lot of abnormal movements. Gabapentin can be remarkably helpful. So and it's also even people use it for like mood disorders. I think that. And fibromyalgia, of course, it's a very common.
It's kind of like acetazolamide. It's probably worth a try.
It definitely is worth a try. And I always warn patients, so the formulation is such that, you go on what seems like really high dosages, but it's just the way that this particular drug is made, that this is the dosing you need. And so with regards to dosing, I generally start 300 milligrams at night. I find 100 milligrams, unless you're a 6-year-old, it's just useless. But I do 300 milligrams at night, because it can help you sleep. But their bodies does get used to it, so then I add a second. Technically, the pharmacokinetics is such where it should be dosed 3 times a day, so you don't have a dip in the levels. But I start it once at night, and then I'll add a morning dose, and then I may or may not add the middle of the day dose, depending upon how they're doing. And then I'll titrate up from there, and I've had some patients, and I still have patients on like as high as 3,600 milligrams a day, and they're doing great, and they love it. And, they've gotten over, initially you can feel like, whoa, am I stoned? Am I drugged?
Yeah, I was going to say the negatives are it can make you sleepy.
Yeah.
And it can make you foggy.
Yeah. Yeah, but, when you have a true neuralgia, and it helps, patients don't care how they feel. They just don't want that. That pain is horrible.
Yeah. Have you found it helpful in small fiber neuropathy, biopsy-proof small fiber neuropathy?
No, I have not.
It's
a shame.
It's not fair.
No, it's not fair. It's not fair. I mean, I think the pain of small fiber neuropathy is unique in terms of the quality of the pain, and specifically the pathways of that pain pathway that gabapentin just doesn't touch.
Right.
And I don't. It's one of those things. I have this list of things of topics that I want to do a deep dive in to understand better. That is on my list, and I just don't understand why it doesn't help the small fibers, but it doesn't. Yeah. It does help the large fibers, and it helps those cranial nerves. And patients who suffer when you have a cranial nerve neuralgia, there's no worse pain, frankly. It just destroys your day, especially trigeminal neuralgia. Like you can't brush your teeth, you can't chew.
Right.
So anyway, so I really like gabapentin for that reason, and I will often go to pregabalin just so that you only have to take that twice a day. And again, the dosing sounds a lot less.
Yeah, but I never willingly or initiate a pregabalin prescription.
Yeah.
Because GABA works fine, and my experience previously, when it first came out, is it was very difficult to taper the patient off of pregabalin. It could be really difficult. Whereas GABA, you still have to taper to stop it, but it was sort of easy.
Yeah. Well, I think, that's interesting that you've had that experience. I'm not so sure I've had that experience, but I do use a lot of gabapentin, so I'm just.
And you do taper it if you have to stop
I do taper it, for sure, because it still technically is an anti-seizure medication.
Right.
So anything that's ever been used for seizures, you have to taper because it does have an effect on neuronal activity. And so, and that's actually how it works as a neuropathic pain medication. It reduces the activity and the reactivity, especially if there's mast cells involved, of the nerves, and that includes, by the way, the peripheral nerves as well as the central nerves. So it's never used as an anti-seizure medication any longer. Maybe in some less cosmopolitan areas, but because as I've said before, we have way better things in our arsenal. But it still has been used as an anti-seizure medication, and it still is technically an anti-seizure medication. So you absolutely have to taper it when you've been on it for a long period of time, especially if you've been at the higher dosages that I've mentioned. If you've just been on it once at night, you can go to the 100 milligram tablets for a little while, and that's okay. But if you've been on certainly 2 or 3 times a day at higher dosages, you absolutely have to taper it.
Right.
Yeah.
Good.
I think we're out of time.
Okay.
I can go on and on about. I love drugs.
3 drugs.
I know.
think we should make this a.
That's another series.
Episode thing.
A drug series.
Or a drug series. Yeah.
I like that idea.
Picture on 2.
Yeah. Right, because there's so many different drugs that we use.
We'll call it untangling.
Untangling, unraveling.
Right.
That's a really good idea. This is the first part of our drug series.
Right.
So we have our live series, we have our patient series, and we have our drug series.
We better keep track of what we did. So we did LDN, Cromolyn, and Acetazolamide.
And Gabapentin.
That was good. We covered
That was
4
good.
drugs.
We covered 4.
I didn't think we'd get to 4.
Yeah, there's a whole list of them. If you look at the Patreon pages, lots of drugs to discuss. So.
Yeah. Great.
All right, awesome. My mouth is dry.
Well, thank you
again. I
again.
have broken ribs. I just reached for my juice, and that hurt.
Oh, gosh.
All right, well, thanks for joining us. And we will see you next time, right?
Right. We're recording again in 2 weeks?
In 2 weeks, yeah.
When is
and then
when
our next live is May 4th. That's a Saturday, right?
I think so.
Yeah, May 4th is, and I'll post it on the Patreon page, but it's May 4th. Usual time, usual place.
Okay.
And
send your comments.
Yep.
Send your reactions to the previous episodes. And try to get your doctors to watch, please, or have them call us or contact us.
Maybe we should just take our show on the road. I'm serious. Like, just rent out
We'll go
town
to Vegas
halls.
and we'll get one of those theaters there.
No, I mean where we can go to people, like,
Right.
not people have to come to us.
Yeah.
And we just rent out town halls throughout the country.
That'd be good.
A traveling show. And we're going to be doing an Ask Me Anything for Remission Biome. Don't forget that. May 1st, I believe.
Right. For
Renegade
the
Research.
global thing.
No.
You mean the round table group.
Right, the
Yeah,
round table
right.
group. We did the
What's
round
the date
table
on that?
already. I think it's May 1st.
Okay.
That's a Wednesday.
Right.
Or maybe it's May 3rd. Maybe it's May